Good evening, everyone. Thank you all for joining us tonight for a conversation that we're going to call Fall into Wellness, a community discussion on the essential health screenings and vaccines. I'm Dr. Rashida Monroe. I'm a pediatrician at WakeMed Health and Hospitals, the director of the Keenan Urban Scholars, and campus director at the UNC School of Medicine at the Raleigh site. And I'm really excited to be your moderator this evening. This event was made possible by Alliance Medical Ministry, who is generously hosting us here in their sanctuary. Kim Whitley, the medical director and the director of development and communications, is going to share a little bit more about Alliance Medical Ministry. So, Kim, we welcome you to the stage.
Thank you, and we're so glad you could join us. This is the sanctuary at Alliance Medical Ministry, but behind us we have a full medical clinic with a staff of 35 doctors, clinicians, other patient services that we serve in Wake County, over 2,000 working uninsured adults. So we serve patients in Wake County who do not qualify for Medicaid, but are employed, but do not have their own medical insurance. So to be a patient here, you do apply, and we have a full service clinic that has, as I said, doctors as well as social workers and behavioral health counselors. We have a registered dietitian. We have a farm who's and a full-time farmer who's also our wellness coordinator. So we have comprehensive health care here that we can offer to our patients, which is just an amazing thing. And so we do total holistic care for our patients. And if you are interested in learning more about Alliance Medical Ministry, we'd love to hear from you.
Excellent. Thank you so much for sharing that with us. Amazing services provided for the community here. So, we are going to discuss some preventative health strategies and screenings and vaccines. But before we get started with that, we want to share some updates about COVID-19 and how to continue to stay safe. Currently, we're seeing the impacts of long COVID. It's defined as symptoms or complications after a COVID infection that can last for weeks, months, or even years. These can include a wide range of things like respiratory issues and beyond, like hair loss and trouble concentrating. Through the various studies over the years, we have seen that keeping up with your COVID-19 vaccines is the best way to help reduce the risk of long COVID. Studies suggest that one dose of the COVID-19 vaccines reduces your risk of long COVID by 21%, 2 doses decreases it by 59%, and 3 or more doses decrease the risk of long COVID by 73%. So, pretty impressive. The updated COVID-19 vaccine this year will be widely available in September, and it's recommended that everyone get vaccinated by the end of October before we enter the season, and everyone 6 months and older is recommended to get the latest version of the vaccine, which provides protection against the newest variants. If you are higher risk, please discuss with your physician or medical provider if there are any additional doses that you should get. While the vaccine is no longer free, there are still many options to get it at no cost. You can visit vaccines.gov and enter your zip code and find locations that provide free vaccine. You can also pick up free COVID test kits at various community access points throughout Wake County. Visit covid19.ncdhhs.gov to find one near you. So, as we think about how to protect ourselves against COVID-19, it's important to consider other preventative measures to keep ourselves healthy. Early detection through regular screenings and checkups significantly improve health outcomes and quality of life. These screenings, which are medical tests used to detect disease or risk factors before symptoms appear, are vital tools. For example, routine blood pressure checks can help manage and diagnose hypertension, which is a leading cause of heart disease and stroke. In North Carolina, the leading causes of death, including heart disease, cancer, and COVID-19, disproportionately impact Black and Hispanic individuals. It is crucial that we acknowledge that these disparities are driven by a combination of factors such as systemic inequities, lack of access to health protective factors, environmental factors. There's not something inherently wrong with the biology of Black and brown bodies that put us at increased risk of these things, but structural factors impacted by historical policies and practices. So it makes these screenings even more important. By identifying these diseases early, screening can improve treatment outcomes and reduce the impact of these conditions. While Black women in North Carolina are less likely to be diagnosed with breast cancer than white women, they have higher mortality rates and often have delayed diagnosis and other barriers to healthcare that make their outcomes from breast cancer worse. Regular mammograms to help detect breast cancer are really important. We're going to discuss some really important health screenings, including regular mammograms for breast cancer. And in just a second, I'm going to introduce you to my three amazing panelists, colleagues, and friends that I get to work with. We will be discussing screening for cervical cancer, prostate screenings, colorectal cancer screenings, diabetes screenings, blood pressure, and cholesterol screenings. Black and Hispanic men in North Carolina face higher risks of diabetes, heart disease, and prostate cancer. And the American Cancer Society estimates that there has been a 65% increase in prostate cancer between 2019 and 2022, the largest increase for any major cancer. Today, 1 in 6 Black men will be diagnosed with prostate cancer. So, let's get to it. I would like to have my panelists briefly introduce themselves. First, we'll start with Dr. Stephanie Etienne.
Thank you, Dr. Monroe. I'm Stephanie Etienne, and I'm a family physician. I've practiced for almost 20 years now. Most of my years have been spent working in Southeast Raleigh at the health department and what used to be Rock Quarry Road Family Medicine, which is now Advanced Community Health. I'm currently a medical director for utilization management for WellCare of North Carolina, and I'm still very active in advocating and educating underserved populations in an effort to improve healthcare outcomes.
Fantastic. Thank you for reminding us. You said advocating, and being a physician advocate is really important, but patients also advocating for themselves is really important. Being proactive and having these conversations to help empower yourselves and take care of your health, talking with your primary care physician, that's your family physician, internal medicine, or a pediatrician, to help develop a personalized plan for your screenings and preventative measures, making sure that you talk about your family history so that your provider can understand the risks and help you tailor this plan is really important. Thank you, Dr. Etienne. Next, we'll welcome family physician, Dr. Jacqueline Hicks.
Hi. Hello. Okay. I am Dr. Jacqueline Hicks. I am a family medicine physician currently employed at WakeMed North Raleigh. I have spent time here at Alliance, actually, as a former employee here for about 4 years. And I believe in informing the patient and educating the patient so that they can make the best choices for their health. I also open communication with the patient and working as a team to be sure that we are optimizing their health.
Excellent. Welcome, Dr. Hicks. Dr. Burkett, I'll let you introduce yourself.
Thank you very much, Dr. Monroe. I'm Dr. Edwin Burkett. I am also a family physician, and I am the medical director here at Alliance Medical Ministry. I've been here for 3 years, since 2021, and prior to that, I was in the Air Force and retired as an Air Force physician. So obviously, I'm very active proponent of holistic care and prevention, and that includes this screening that we're going to talk about. It's very passionate about that. We appreciate this forum to discuss it.
Excellent. So before we get started talking about adult health screenings, as the sole pediatrician on the panel, I'll make a quick plug for annual well child checks. It's really important that children stay up to date with their well child visits, annually discuss with their pediatrician what screenings and vaccinations are needed. We also do screenings for mood and anxiety and depression when we see your children. We're seeing increased rates of some mood disorders in children and adults, especially since COVID and beyond. One important thing I want to remind people of as we're getting back into school for most students is this is the time right now to go ahead and reestablish those good bedtimes routines, to kind of roll those wild summer schedules back to your school schedule ahead of school starting, to get back into your screen time limits, which are two really important things that you can do to help your children start off on the right foot as we start school. Also, to reduce illness as we're starting school, reminding your children wash their hands, especially before touching their face or eating their lunch or snack. Keep them home if they're very ill. Certainly, if they have a mild illness, if possible. And we'll talk a little bit more about some children's health screening as we continue. Okay, let's get started. So let's start with mammograms, since we talked a little bit about breast cancer earlier. Dr. Hicks, remind us about mammograms. Who needs mammograms? At what age? And what is the purpose and what do we expect during a mammogram?
So it is recommended that individuals who have breasts obtain mammogram screening beginning at the age of 40, according to the American Cancer Society. These annual mammograms should take place annually until approximately your postmenopausal or around the age of 55. There are multiple guidelines out there, but this is the one that I follow. These mammograms are able to detect precancerous changes as well as breast cancer in people who have breasts. After the age of 55, you can have a mammogram every 2 to 3 years, up until usually the age of 75. It's so after you're postmenopausal, you don't need a mammogram yearly unless you've been diagnosed with breast cancer and have been treated with breast cancer, or you have abnormalities that are not cancer and they recommend additional screening. You may also have to have ultrasound depending on what is found as well. So it all depends on what is found during your screening mammogram.
Okay, thank you for letting us know that. So again, I'm a pediatrician and I don't know these adult health screenings. So I just learned something. I didn't realize that I get to space out my screenings at some point in the distant future. I am not, what was it, 55? Was that the change?
55.
55,
Usually
okay. Postmenopausal or 55, so, okay. Yeah. And for women who are like approaching 40, or maybe they're in their 40s and they haven't had a mammogram yet because they're scared, because you've heard like it hurts or it's uncomfortable, what would you say to women?
I would say it's only uncomfortable temporarily. Mammograms can be uncomfortable. I usually find that the larger the breast, right, the less likely it is painful. But it's temporary, and it's worth the couple of minutes to have your breast smushed to make sure that those breasts are healthy.
Absolutely. Very temporary. And as a mom of boys, it was no more uncomfortable than the, I don't know, kicks to the stomach, neck, or groin from toddler boys. You know, it's just
absolutely. If you've
mild discomfort.
If you've had a baby, nothing compares. So, and it's very short-lived.
True. Okay, perfect. All right, so annual mammogram starting at 40. And if they find something on mammogram, or even if you have dense breast tissue, you may be recommended to get more screening, right?
If you have dense breast tissue, there is an option for an MRI of the breasts. This has to be referred from your primary care physician, so everyone should always have a primary care plug there. But MRI can actually look more detailed than a mammogram at identifying abnormalities in dense breast tissue. On a mammogram, dense breast tissue is white, but a mass is also white. And so it can be hard to determine whether you have any abnormalities in your breast. You should also make sure that you're checking your breast every month. You're with them all the time. Why not? And making sure that you don't feel any lumps or bumps. The breast should look the same on both sides. Okay, they should feel the same, and also check underneath the arms where your breasts drain.
You're with them all the time. Why not? That's my favorite tagline. Maybe I'll get a bumper sticker that says that. Okay, thank you. That was very helpful, especially the part, don't forget to check under your armpit where the tail of your breast is. Thank you for reminding us of that. Okay, Dr. Higgs, I'm going to stick with you. We're going to talk about Pap smears and cervical cancer screening, people with uteruses. Remind us about who needs Pap smears and when and why.
Okay. So Pap smear screening begins at the age of 21. Years ago, it used to be that you get a Pap smear every single year when you become sexually active. That is no longer the case. Currently, according to the United States Preventive Service Task Force, you start at the age of 21 and it checks for cervical cancer and screening for human papillomavirus. So we usually do the two tests together. For those of you who do not know, human papillomavirus is the virus that detects cervical cancer and genital warts. Okay, so that's the virus that causes you to have cervical cancer and genital warts. And so the Pap smear screens for that up until the age of 30, every 3 years. Now they've extended it to 5 years. A lot of people are like, well, why? When we used to get it every year. And that's because of the Gardasil vaccine. So Gardasil is a preventive vaccine for human papillomavirus. And so it's given to males and females to minimize the incidence of human papillomavirus. So with that being said, because of the Gardasil, we've had decreased incidence in cervical cancer, allowing us to not have to get Pap smears every single year. It can also detect other abnormalities of the cervix as well. That screening starts at 21. Screening ends at 65 years old, unless you're at risk, then you can continue. Screening after 65 years old can also take place if you develop any vaginal bleeding, okay? So vaginal bleeding after you've stopped your periods, which is on average around the age of 52, then you should definitely be evaluated because that's suggestive of cancer until proven otherwise. And so that's when you would do additional screening.
Awesome. That was really helpful. So a couple of things. One, a reminder that after your menses has stopped, vaginal bleeding needs to be evaluated. Do not assume, oh, I've just had the return of my period, right? That needs to be evaluated. Also, thank you for telling us about the HPV vaccine, Gardasil, one of my favorite vaccines. We give this to children at their well visit starting at 9 years old. We can start giving HPV vaccine for boys and girls, which is incredible because when we are able to get those now 2 doses of vaccine in before you're ever exposed to sexual activity, which we really hope we are able to do that well before when we're starting that early, we're able to reduce the risk of these cancers by 98, 99%, which is just phenomenal. also understanding that not just cervical cancers and genital warts, but a lot of head and neck cancers are caused by HPV virus. So really important vaccine. Go Gardasil. Okay. I get no kickbacks from anybody for Gardasil.
Absolutely.
All right. Fantastic. That was very helpful. Dr. Burkett, I'm going to hand it over to you. Talk to us a little bit about prostate cancer screenings. People with prostates need screenings starting at what age, and tell us more about how that's done.
Fantastic. But before I do that, I want to talk about, I think the most important screening that people need to have is establish their care with a primary care doctor like these great folks here. And this is what we do. So the most important thing is to have that conversation with your provider, with your primary care provider, your family doctor, your family advanced provider, so that you can determine these things together, what to do, when to do it, and follow the guidelines, but everybody's individual. But the first step is to establish that care relationship and that trust with us and the patient that we love to have, so that we can get healthier. So that's the first thing I think of. And that rolls right into the prostate screening, which is, as you say, very it's a unique thing in that a lot of men, most men at some age, no matter what you do, if you die at 97, if they cut you open and took out your prostate, there may be some prostate cancer in there. It can be a very slow-growing thing, but the idea, we want to catch it early because there are that small group of folks at higher risk that it's more rapid and you get prostate cancer that can kill you. So that's why we do the screening, and we have that conversation with each patient, each man, each person with the prostate to determine when and where they should get that screening. The way we do the screening most of the time, and the simplest way, is with a prostate-specific antigen test. It's a simple blood test, and we can measure the level of that PSA, or prostate-specific antigen, and that gives an idea of how large the prostate is, or if there is an abnormal growth of prostate cells. And that's how we determine. If that's high, then we need to evaluate. The reason why it takes a conversation is because just a larger prostate or an inflamed prostate can also make that number go up. And so we want to decrease the risk of doing some biopsies or evaluation or expensive evaluation when it's not indicated for prostate cancer, but we have that abnormal number. So that's why it takes that conversation. It takes determining when to test for someone. Usually at 40 years old is when we want to start to begin that conversation and possibly do that testing. So that's the basics of prostate cancer screening and so forth. What other questions?
Excellent. That was great. You brought up what we call shared decision making, right? It's not our job or goal as physicians to tell someone what to do, but it's our job and goal to inform and to have a conversation and to make a shared decision. I always like to tell my students and residents as I'm teaching, we're the experts in medicine. They're the experts in their body and their family, and so together we can make an informed decision and decide how to move forward depending on what the risk factors and what other concerns are. So perfect. That was helpful. Really important about having that conversation and building that relationship with your primary care provider. All right. So we've talked about some screenings that are specific to anatomy, right? Prostates and breast and, uteri, cervices. Let's talk about some more general screening that everybody's going to need. So, Dr. Etienne, I'm going to come to you. Let's start talking about a really important one, diabetes screening. Tell us about diabetes screening. Who needs to be screened for diabetes and why?
Well, the American Diabetes Association recommends that adults are screened by the age of 45. However, most adults have some risk factors for diabetes. So pretty much everybody should be screened, really starting in childhood for the most part. So pediatricians are screening children appropriately. If you have risk factors, specifically family history, obesity, you have high blood pressure, high cholesterol, you are at increased risk and you should be screened at least annually. This is why it's very important to have a primary care provider and to attend your annual exams. Diseases like diabetes, in the early onset of the condition, you may not have any symptoms. You'll have no idea. And people who think they're healthy and don't have any medical problems, they may choose not to go and get those annual exams. So you will have no idea whether you're pre-diabetic or diabetic unless you're tested. And the diagnosis is made by what's called the fasting blood sugar or hemoglobin A1C, which is a test that measures the level of blood sugar control over 3 months. So it's important to get those tests done. Even if you're normal, if you gain weight, if you get older, your risk goes up for developing diabetes. So it's important to ensure that you're getting tested and do things to help prevent the development of diabetes, like eating a healthy, balanced diet, exercising, maintaining a healthy weight. Those things are essential in decreasing your risk. Of course, there are genetic factors. Family history is a very strong risk factor. So if you have a family history, you have to really work harder on those modifiable factors, things that you can control to prevent developing diabetes. Unfortunately, I believe it's at least 50% of the population are pre-diabetic and don't know it. So pre-diabetes can progress to diabetes. But the good thing is, if you go to the doctor and get screened and are diagnosed with pre-diabetes, you have the opportunity to make some changes and decrease the chance of progression to diabetes. So again, that's why we keep stressing the importance of having a relationship with the primary care provider and getting those exams and screening tests done, because you won't know, because in most cases you're not symptomatic. When you become really symptomatic, it's usually when the diabetes is very uncontrolled, and people with uncontrolled diabetes tend to have a lot of thirstiness. You want to drink a lot. You may urinate more. You're fatigued. You may have night sweats. You just don't feel well at all. You may have visual changes, dizziness, and you're just wondering what's wrong with me. And diabetes could be the thing that's wrong with you if you have those symptoms. You don't want to wait till it gets to that point before you're diagnosed with prediabetes or diabetes.
Thank you. That was excellent. Thank you for reminding us that diabetes is completely preventable and treatable, especially when we find out about it early, right? One, when we're addressing risk factors and screening for prediabetes. But once it's, uncontrolled and undiagnosed, we're talking about impacts on our vision, our heart, there's not an organ system that's not impacted. Our kidneys, there's not an organ system that's not impacted by diabetes. So it really is very important. The other thing is, my dad passed away with complications of diabetes. It's been, I think, 6 years now. And I can think of all my life growing up with him with diabetes, and how much work he had to do to control his diabetes, like checking his blood sugar and giving his insulin. And all of that has become a lot easier, like the way people are able to monitor their blood sugar and things like that. Can you talk a little bit about just a little bit about the treatment of diabetes, with continuous monitors and what am I trying to do? Insulin pumps and things like that.
Yes. Most people, of course, if caught early and their diabetes is controlled, they don't, they won't have to have a insulin pump or a continuous monitor. In people with well-controlled diabetes, it's usually managed with first diet and exercise. That's always there. In many cases, you do have to take oral medications and possible other injectable medications, including insulin, if necessary. it's essential to check your blood sugar, even if you are not on insulin. It's important to check it regularly. If it's uncontrolled, you have to check it more often, and you may have to see specialists to help you monitor and control it. People can live, you don't want to be a diabetic if you can prevent it, but just because you are a diabetic, it doesn't mean that your life is over. You can do things to where you are preventing the development of complications, and that's the key thing. You want to prevent developing kidney disease, which could progress to having to be on hemodialysis. You may know people who are on dialysis. I think probably most of us know someone who's on dialysis due to their diabetes or high blood pressure. You want to preserve your vision. One of the big complications, too, of uncontrolled diabetes is visual changes and vision loss, as well as stroke. I mean, like we said before, diabetes can impact pretty much every system of the body in a negative way. But it doesn't have to be that way. It can be controlled. And there are so many tools and resources. I mean, you can work with dietitians, your physician. You know, there are many things that can be done to decrease your risk and decrease the chance of progressing to complications.
When I think of an ounce of prevention is worth a pound of cure, diabetes really is something that fits into that, right? Okay, so as we're talking about screenings generally for everybody, we talked about diabetes. The other big two we want to talk about are blood pressure screenings and cholesterol screenings. So Dr. Burkett, I'm going to ask you to tell us about blood pressure screenings. Who's getting checked for blood pressure and or for high blood pressure, and what are some of the kind of complications or things that can happen with uncontrolled high blood pressure?
Okay, so blood pressure is, again, another one of those things that affects all of us, and we need to check everybody. So she said, our pediatrician expert over here, also, and family docs. I used to see kids a long time ago, and we do blood pressure on kids too. So the pediatrician, we start with that. Start in the youth, and you have to check it and measure, because it may be detected early on if there's other conditions that can cause high blood pressure than the things we think about. It's not always just when you're 40 and because you ate too much salt. You know, it can be other things that can cause elevated blood pressure. But the most of people we treat, yes, it is preventable. It can be at least controlled early and prevent the bad side effects of it. So the prevention thing, I know this is not the fall into prevention discussion. We need to have one of those, because primary prevention is kind of things we keep hitting on. We need to have a different conversation about that. But I don't want to digress too much. So blood pressure. What are the bad things about it? The first few symptoms if someone has high blood pressure would be they may have a headache. They may have a headache on a regular basis, and they're wondering why I always have a headache. And it may be come on during the day, you know, while they're working or whatever, and it's maybe because their blood pressure goes up. They could have chest pains. That would be a late progression of high blood pressure. And it leads to the reason why we really want to treat blood pressure in the first place, why we want to detect it, screen it, and find it, is to prevent heart attacks and cardiovascular disease. In particular, you know, not just the heart, but the brain, or what people will call a stroke. And those are the things that are deadly and they're destructive. It's not just, if they don't kill you, they maim you. And that's very bad. I mean, we've seen it, and we have patients and we have family members who have that. And that's a very bad thing to live with. And it could be prevented in the secondary phase if you have high blood pressure and can control it with medication, or hopefully with other means. Then you may prevent those bad cardiovascular events. So that's really what we're trying to do. The way we screen it, take a blood pressure, and again, that annual physical exam that Dr. Etienne was mentioning, that is the way to do it, and do it every year, and then we can track it. And if there's one abnormal high blood pressure, we don't stop there. We want to rescreen it and see if it's a trend, and then what to do about it. So food, nutrition, exercise, the things we discussed, and then medications if needed.
Awesome. Thank you so much. That was really helpful. You mentioned fall into prevention. I like you bringing that up because all of the conditions we're talking about can be prevented. So you mentioned a healthy diet, balanced diet. You mentioned exercise. I like to say, in kids, we say active play, an hour a day of active play. Exercise sounds hard, but active play sounds fun. And then smoking cessation, or never, even better, never starting, right? Really important to help prevent some of these diseases and complications. Okay. Dr. Etienne, I'm coming back to you. Cholesterol screenings. Remind us who needs cholesterol screenings and when, and why does it matter?
Well, it's recommended that in adults, by the age of 20, you have your cholesterol checked. Well, as we mentioned before, we usually start earlier, in our pediatric patients, especially if they have risk factors. We tend to start earlier. If they're overweight, have a family history, we tend to screen earlier. And the reason why we do cholesterol screenings is because high cholesterol is one of the biggest risk factors for heart disease and heart attacks. And high cholesterol, there's no symptom of high cholesterol. Your cholesterol is high. You have no way of knowing that you have high cholesterol unless you do blood tests to measure your cholesterol levels. And like all of the other conditions that we mentioned, high cholesterol can be prevented in most cases. You have some more rare cases where people have disorders that make them more likely to have high cholesterol no matter what they do. But in most people, it's because of our lifestyles, because of what we eat and what we don't eat. Like we're not eating healthy foods, and we're eating foods that are high in bad cholesterol, and they increase our cholesterol levels. So high cholesterol can lead to heart disease by causing depositing of plaques in your arteries, and that can lead to heart attack and stroke, actually. So it's important that people are screened at least annually for cholesterol. If you see that your doctor can determine whether your levels are increasing to a level that's unfavorable. If you have more certain risk factors, you have a lower threshold for cholesterol. If you're an older person, if you've had a previous heart attack, if you're diabetic, you really, really want to make sure your cholesterol is controlled. So you're more likely to be put on medication at a lower level of cholesterol if you have those risk factors, because you are at a tremendous risk for heart disease if it's not treated. But diet and exercise can really make a difference in most people. It's sometimes difficult to eat a healthy diet, but that's a big motivation to not have to take some of the medications, because some of those medications have a lot of side effects. One of the most common medications are statins, and many people have like leg pains, really bad leg pains, and muscle aches due to the medications. So do what you can to try to prevent having to be on medications. But if you have to, you need to be on them, because not taking the medicine if you need it will eventually lead to a worse outcome, like a heart attack or a stroke.
I keep hearing some themes here: diet and exercise and prevention. When we think about diet, so high fiber foods, vegetables and fruits, and limiting fast foods and saturated fats. Anything else from a diet standpoint? I always remind my in kids, really no sugary drinks. We just don't recommend any drinks with sugar or artificial sugar for that point. Water and milk is what we recommend for kids. That's it. Is there anything else from a dietary standpoint, just kind of big picture things that we recommend as we're talking about that for prevention?
Of course, fruits and vegetables. And if you eat fats, eat healthier fats. You don't want to eat a lot of saturated fats. You want to eat things like, lean meats, like lean chicken. Fish is really good because they have healthy fatty acids that are actually good for your cholesterol. Nuts, things like that are really good. You want to make sure you don't eat a lot of fast foods. What I tell people is better to, if you can, make your own food because you know what you're getting. You know what you're getting. If you go to restaurants, a lot of times there are a lot of sauces that are high in fat, unhealthy fats, and things that are not necessary, and salt and sugar. So you can have the control over what you're eating, and you know exactly what you're putting in your body.
Okay. That's helpful. Dr. Hicks, I'm going to ask you about colorectal cancer screenings. So we talked about kind of the big three: diabetes, blood pressure, cholesterol. But let's go backwards to some like anatomy screenings. Everybody has, well, most people have a colon still. And tell us about who needs to be screened for colorectal cancers.
Okay, so colorectal screening currently should begin in everyone at the age of 45. African Americans in particular increase risk of two types of cancers, both of screenings we've discussed so far: prostate cancer and colon cancer. It was previously that everyone except for African Americans would start at the age of 45. African Americans would start at the age of 45, everyone else would start at 50. They have changed those guidelines due to the increased incidence of colorectal cancer that everyone starts screening at 45, according to the United States Preventive Service Task Force. This screening test is the main test for colorectal screening. It is the best test out there for colorectal screening, and nothing actually replaces it, particularly in African Americans, because the screening test itself will allow the removal of precancerous polyps and precancerous lesions. They do have Cologuard out there for screening for colorectal cancer, and that's great if you're not high risk. Okay, they have a new one out called Shield. It's great if you're not high risk.
And that's where you're just doing like a stool sample and sending it in,
yeah,
right?
The colorectal, the Cologuard is a stool sample you send in. That's every 3 years. They'll send you a kit in the mail, and then you'll send that kit with your stool sample inside back to them, and they will analyze it for blood. If that's positive, though, guess what you need? A colonoscopy. Okay, so there's really not a test other than the colonoscopy that's definitive. The Shield that just came out is fairly new. It's a blood test. We haven't started using that screening, but those are the three types of screenings. You can also do Hemocult in the office every year. That's when your physician, your primary care physician, will do a digital rectal exam to take a digital stool sample and put it on a card to check for blood. You can have that done in your primary care doctor's office every year if you don't choose to have one of the other tests that I just mentioned. I do recommend colonoscopy. And if that test happens to be completely normal, then you won't need another one for 10 years. Okay? So it starts at 45. If that test is abnormal for any reason or they remove any polyps, then the gastroenterologist will recommend screening anywhere between 3 and 5 years, depending on how many polyps are found and what type of polyp is found. So even more reason for you to follow up. The other thing that I think it's important to mention is if you have any changes in your bowel habits, meaning you develop constipation, you develop abdominal pain, or any changes in your stool, or you see blood in your stool, then you need to be evaluated. And that goes regardless of what your age is.
That was really helpful. And it just reminded me that I have my first colonoscopy scheduled in a couple of months. I'm really looking forward to it, actually.
The worst thing is the prep.
Yeah. I remember my husband did this last year, the prep, but he had a really good nap with that colonoscopy. So I'm looking forward to it.
It's the best 15 minutes of sleep you'll get.
All right, fantastic. That was really helpful. I want to make sure that we open up to our audience. We've kind of gotten through the background information that we want to make sure that everyone had. But please let us know. Just raise your hand or come to the front if you have any questions for us. All right.
In a few more years, I will need to have a second colonoscopy. So, is there something I can do instead of going through that process again? Because now, when I first had it, some polyps were removed, but they were non-cancerous or benign. So I don't think you would need to know my medical doctor, but nonetheless, is there some kind, you were talking about some other little test other than going through the procedure that maybe I could take instead of going through the colonoscopy procedure?
So repeat that a little bit so our
Okay, the question was if you have a colonoscopy and you're due for another colonoscopy, but they found non-cancerous polyps in your initial colonoscopy, are there additional testing other than a colonoscopy that you could do instead? Okay. I personally would say no. And the reason why is because even though those polyps were non-cancerous, I would want them to go in and take a look to make sure that you do not develop cancerous polyps that need to be removed.
Okay, so Dr. Hicks, you said to us the screening test, either the blood test or the stool card, was something that was an option for people who are low risk. But if you've had polyps removed, you are no longer low risk and you need to get colonoscopies. That's what I'm hearing.
That is correct.
Okay, got it. Awesome. Miss Chloe. That's an excellent question. What are polyps, Dr. Hicks?
Polyps are growths in the inside of your colon that they can appear sometimes normal or they can appear abnormal or inflamed, and that shows that those polyps are abnormal and they should not be there. So your colon should be just smooth.
Like a tube.
A smooth tube. And sometimes when they go in, they see little lesions on your colon that are not supposed to be there.
Okay. So instead of a smooth tube, you've got little mushroom growths coming off of the smooth tube, and that shouldn't be there. That's right, Chloe says, ew. Let me have, let's see, in the back here, and then I'll come back to you up front.
If someone is diagnosed with diabetes, how often should they go and visit their primary care physician?
It's an excellent question. If someone's diagnosed with diabetes, Dr. Etienne, how often should they be seeing their primary care doctor?
That's a great question. At the very minimum, it is advised to follow up every 3 months so that you can have specific blood tests done to make sure that your diabetes is under control. You can get nutrition counseling and just overall counseling about your disease, and also to check blood work to make sure the diabetes isn't affecting other organs like your kidneys. There's a lot of, when you're diabetic, it's not just the diabetes that they have to monitor. They have to monitor basically all of your organ systems to monitor for other complications. You also need to get annual eye exam. You have to get a foot exam because people with diabetes are more likely to develop neuropathy and what's called calluses that can eventually lead to ulcers. So there are a lot of things that need to be checked on a regular basis. If you are uncontrolled, you may have to go more frequently to see the doctor, and you may be referred to a specialist called an endocrinologist if you're uncontrolled and your doctor needs some help in managing your condition. But at the very minimum, every 3 months.
Excellent. I saw a question up here again.
I just want to follow up about the colonoscopy that you're talking about. The doctor recommended that I eat more foods with more fiber and drink more water so that I don't get constipated. I mean, that's just real life. And so I've done that and I'm not having the problem that I had in the past. Also, I want to mention, now I don't have diabetes, but I do know of someone that does have it, and they don't like to use the device to stick their finger, to draw some blood. So is there something else that can be used other than that?
Excellent questions. 2 questions. So first, answer the question about the diabetes. There's something besides a finger stick that someone can use to monitor their blood sugar regularly.
Yes. Diabetes has come a long way over the last few years. There are internal monitors that can be placed, what's called continuous glucose monitors, that they basically place like a little electrode right under the skin, and you can use a device. You just touch it, and it tells you what your sugar is. So you don't have to stick yourself. So you're able to monitor. And a lot of people are doing that now so that they don't have to prick their finger.
That's awesome.
That's that for the family member, but it's expensive.
Yeah, it can be. It depends on probably the insurance plan, unfortunately. And
like she said, yeah, with the insurance plan. The reason why I'm going to chime in is because, Alliance Medical Ministry takes care of uninsured patients. So a lot of the things we're talking about, it depends on what your insurance can cover. And for us, we have some partners that help us do certain things, but we just can't get everything for patients who are uninsured. So continuous glucose monitors, though, there are some programs for people who are uninsured and meet certain qualifications from a company, particularly Dexcom is one of them, that they can apply for assistance and get the Dexcom glucose monitor for free. Some of the other companies may be going to that. And then also I know that one of the companies now has an over-the-counter version sensor, continuous glucose monitor, which might be less expensive, may have a little bit less of the capability for your doctor to monitor it too, but they're available. So that's, like she said, the diabetes care is progressing, but other than sticking the finger or the glucose monitor, there's no real other way. So, and then I'll just chime in on the nutrition part too, and I'll let the colonoscopy discusser do that too, But I wanted to mention, so nutrition, and we keep hitting on that, and there are, they mentioned all the right ways of what to eat and what not to eat, and we can mention it, we talk about it, and it's hard to grasp, because most people want to say, what diet should I follow? What do I do? Atkins? Do I do this other fancy diet? Do I do intermittent fasting and all that such? There's some value in some of those things, but they're very difficult and hard to keep track of. The simplest, most evidence-based or proven by science kind of diet, nutrition plan, I don't like to call it a diet, it's a nutrition plan, is the Mediterranean eating plan. And the reason why they call it that is it's really things that we have eaten in the past. It's the groupings of them and the portions. Because portions are important, but the types of foods. So if you look at the Mediterranean diet, the Mediterranean nutrition plan, it's the most solidified or proven or evidence supported way of eating. And that includes a high fiber nutrition. So I'll let her talk about fiber.
Okay. Yes. And fiber is great to enhance the gut motility. To minimize constipation.
Keeps things moving. That's what that means
keeps
for Chloe, gut motility. Keeps it moving.
Keeps it moving. And what you also want to do is fiber. So your green leafy vegetables, okay? Spinach, kale, yes, collard greens, all of those, they're great for you. But also, you can, when my grandmother, rest her soul, she used to have this big container of Metamucil, okay? So if you cannot get it through a lot of green leafy, then get you some Metamucil and add it, because you also need a lot of water to increase the gut motility. So everyone should really be drinking half of your body weight. Now, borrowing if you have congestive heart failure, right? Because you're limited. But the average person, your average body, half of your body weight. So say someone weighs 120 pounds, on average, you should be drinking at least 60 ounces. Okay, so that's the easiest way to calculate. The average person needs to be drinking at least 64 ounces of water a day. Okay, so that also increases the gut motility and minimizes constipation. But get those green leafy vegetables in, and that Metamucil, if you cannot, will help keep the gut flowing. Whole grains. You can do that. You know, I think bread. Not a lot of bread. Fish is good, right? It goes along with the Mediterranean diet and omega-3 fish oil.
Excellent. Very helpful. I've got a question up here.
Breast cancer survivors, how often should they have colorectal cancer screening?
Breast cancer survivors, colorectal screening. I'm not sure how to answer.
They are more at risk for that cancer, correct? If they've been diagnosed with breast cancer.
I believe that they should just stay up to date with the guidelines per the colorectal screening. No additional screening unless, of course, they've had polyps. Is that what you're saying? So they should definitely keep up with all of the preventive cancer screenings as breast cancer survivors. So all of the screenings for cancer that are appropriate for the organs that you have, you should stay up to date with those.
Excellent. Thank you. Yes, ma'am. Question.
What happens during colonoscopy?
What happens during a colonoscopy, Dr. Hicks?
Wow, Chloe, you're really giving me all the questions here. Okay. So during a colonoscopy, it starts the night before, okay? Normally, you have to take PrEP. Either that's liquid or pills or sometimes both. And that causes you to clean your colon. Do number 2 if you don't understand what I'm saying. And you will be up all night to clean that colon out so that they can then take a camera. They put you to sleep so you don't have to worry about feeling it until you wake up. But they take a camera and they put it in your butt and they look at your colon. So your colon is in your stomach, and so they take that camera and they look at your colon, and then they wake you up. They remove it and they wake you up.
You know, from the audience, we're having maybe a little hesitation or consternation about the colonoscopy, but as Dr. Hicks described, none of that are you aware of. You are asleep. You are in la la land, and you wake up after a really good nap, and that's it. So nothing to be afraid of. You know, we've talked about these screenings. Some, like a breast squish, is uncomfortable, and some, like a finger prick, is uncomfortable, and maybe pooping all night, as Dr. Hicks described, is less than ideal. But the point is, we are trying to save lives, right? We're trying to help people understand their risks for disease, detect disease early, and put a plan in place, one, to either prevent or detect disease early and treat it, because all of these things are, 1, preventable, and 2, treatable. And so I personally will choose slight discomfort to help keep me safe and protected so I can be here for as long as possible for my family. And we have a question up front.
Well, it's not really just a question, but just a general statement. I know that when we consider mammograms, most of the time it's focused on women. You know, it's pink and it's women-based. But in some of my work experience, I've noticed that even in men, you know, and it's found in most of the times it's men that are obese, that men are starting to get polyps in their pectoral areas and are having to go through mammograms just the same. So, you know, is that something in a routine for a man to where maybe in the future they'll look at having to do that for men as well? Or is that just, you know, men that are obese and
So we talked about breast cancer screenings for people with breasts, which includes cis women and trans men. But the question here is for cis men who have who are obese and who have large chest and like fat tissue in the chest. Are mammograms recommended?
So not that I am not aware of that. Now, and I'll let Dr. Etienne also speak on this. I am not personally aware of that, but in your annual exam, at least when you see me, I check underneath all the males' arms and I check their breasts. And I don't know that everyone is doing that. It's just something that I just do because men do get breast cancer. And a lot of times it's them identifying the mass themselves, but I haven't known of screening mammograms in men.
That's correct. For men, it's not recommended for the annual screening like women. The rate of breast cancer in men is much lower. However, it's still recommended that men check their breasts, just the same as we recommend for women. And if they notice any changes that are abnormal, just as in women, they will receive should be receiving mammograms. And if they find things, they should go to their doctor and express that they're having these symptoms and get checked. And if a man has a family history of breast cancer, it is much more likely they're at a higher risk, so they're more likely to get a mammogram and they should be more diligent about checking their breasts for signs that may indicate that they may have cancer. And in addition to that, if they have the family history, they do genetic testing as well. So that's something that we need to mention. You know, when people have a significant family history of breast cancer, a sibling, parent, or multiple family members that have breast cancer, in addition to the mammogram screening, they should have special genetic testing done to see if they carry genes that put them at risk for breast cancer. Because if they do, often there's the option to have surgery and procedures to like what we call mastectomy, removing the breast if necessary, if they are at extremely high risk for developing breast cancer.
Did you have one more comment, Dr. Burkett?
So no, I love that question. That's a great question and great answers. And I think it also speaks to something when we're talking about screening tests. We call them screening tests for a reason, right? Because the science or the statistical analysis of it shows that if we do this test on this group of people, we're going to detect enough disease that we can actually care for and treat. So that also means there are tests out there that if we used them to screen, we would not find enough of the disease to actually do anything to help people. So that's also, again, comes back to our first point about seeing your doctor with your health and your history so that then we can say, oh yeah, this particular man, we need to check, as she said, or this particular person or this particular woman, we need to check something else we may not usually screen everybody for. So that's an awesome question and with a great impact on our health and why you need that relationship.
Thank you all so much. I have learned a lot tonight myself. So selfishly, I really appreciate all of your expertise. Thank you so much for our audience and for Alliance Medical Ministry and hosting us here tonight. As we're wrapping up, I'd like for you all, if you can think of one tip that you think it's very important for people to remember as we're wrapping up. Can you leave us with kind of one parting comment? Dr. Etienne, do you want to go first?
As we mentioned, get your annual exams. Even if you think you're healthy, it's important to get those exams because you won't be able to diagnose many of these conditions without specific testing. And also stress. Stress is one of the biggest risk factors for a lot of these diseases. So make sure you're doing things to decrease your level of stress, self-care. Those things are important. Getting sleep, because if you're not doing those things, you're setting yourself up to be more susceptible for developing disease.
Well said.
Let's see. Establish with the primary care physician if you have not. That's the initial step. Build that relationship. Be honest and open with that physician about what you're feeling, what you're not, and so that they can help you. I would say, even if you don't have insurance, you have wonderful places like Alliance Medical Ministry, and they provide exceptional care as well. So establish with a primary care physician, get those screening tests, check in every now and then to make sure that you are still doing okay.
Wonderful. So I'm just going to give part B to Dr. Hicks because I love her answer. And that is, do the screenings and don't just do it for you. We have these potential screenings you need to establish with the doc and talk about that shared decision making on which screenings you need, but not just for you. It's for your family and your children, and not only for you to survive if you have something bad, but if you're healthy and it's negative, you present a habit that you and your family can follow, that your kids can see. If you eat healthy and do the things like our patient was talking about, improving her nutrition, those things trickle down too. Bad habits, people follow and emulate. Good habits, our children also follow and emulate, and our neighbors and our friends. So do the screenings, not just for you.
It's fantastic. Fantastic advice. I think we all can take those to heart and be healthier for ourselves and for our families and communities. Let's see, my last parting advice will be to be your own advocate. You establish this relationship, you have a primary care physician and they're the expert in their field, but you're the expert in you. And so advocate for yourself. If something doesn't seem right, if you're not satisfied with that first answer, ask again, get a second opinion, advocate for yourself. We're experts and excellent at what we do, but we're not perfect. And again, we don't know you and your body like you do. So, well, thank you all again so very much. I really appreciate your time this evening, our audience, and our panel of experts. And I hope everyone has a healthy fall as we talk about falling into prevention. And we are signing off. Good night.